We're going to switch gears now and talk a lot about vascular disease this afternoon, which is important on the boards and more important in our practices. And so we have a number of speakers who are going to go through things. I'm scanning to see if the good Dr. McBain is somewhere nearby. There he is. All right, yep. Excellent. So, Rob, you can come up, and I'm going to go through your first pre-test questions, and then we'll introduce you and get going. So, thromboembolic and other venous disease is the first topic. So, a 34-year-old man knows a 3-day history of cramping left calf pain. 1 week earlier, he flew to Florida for a college reunion. It's a 4-hour flight from where he lives. He played a lot of beach football, but recalls no specific trauma. On exam, there is mild left calf edema. What is the next best step? Is it D-dimer, duplex ultrasound, CT venogram, MR venogram, or low molecular weight heparin now and then send for prompt imaging? All right, you have to teach them between D-dimer and duplex ultrasound. Okay. Question 2. He's found to have a left popliteal DVT. His CBC and creatinine are normal. He started on rivaroxaban. After 3 months, he returns for follow-up recommendations. He's had no bleeding. What would you recommend? Stop the anticoagulation and start aspirin. Stop the anticoagulation and check his D-dimer. Stop the anticoagulation and repeat his ultrasound. Stop the anticoagulation and obtain a thrombophilia test panel, or just continuing on the anticoagulation. Opportunity.
I feel wanted. Thank you for that. Appreciate that very much.
All right. A 74-year-old man notes a 2-day history of progressive dyspnea and left leg swelling. He's been previously healthy with no complaints. He's mildly dyspneic. His blood pressure is normal. His pulse rate is 93. His lungs are clear. He has a subtle parasternal lift and left leg edema. He's got an elevated troponin and an elevated NT-proBNP. He has a CTA and a duplex venogram that someone scribbled on.
Blue is bad. White is good.
What would you do? Thrombolytic, low molecular weight heparin, an IVC filter, thrombolysis and an IV filter, or surgical thrombectomy? Okay. More opportunities for you.
Okay, good.
All right, so it's my distinct pleasure to introduce the Chair of Vascular Medicine, Dr. Rob McBain, who's going to talk us through what tends to be a neglected aspect of our training, and that is venous disease. And Rob has done this lecture a number of years now. Pay attention. He puts it together really well. We're excited to have you back. Thanks for being here.
Thank you so much, Steve. So I do have a couple of disclosures. My research interest is cancer and associated venous thromboembolism, but I don't think that that's going to be relevant for our discussion today, so, but just as a way of disclosure. So these are learning objectives. We'll go through each of these with each section, and so this is just for your perusal. So the first learning objective is to recognize and diagnose DVT and pulmonary embolism, and we need to use a good algorithm for this based on pretest probability of disease. So whenever we see a patient with DVT, the first thing that we have to do is assess the clinical pretest probability of disease. This is true for clinical medicine. It is absolutely true for the boards. And so I would suggest just a casual look through the Wells criteria. And what the boards are going to want you to distinguish for DVT is, does the patient have a low pretest probability of disease, or does that individual in the stem have a high pretest probability of disease? And so you're not going to memorize that, of course. They're not going to ask you for a moderate pretest probability of disease patient. They're going to say either a very low risk or a very high risk patient. So what you do really quickly, when you read the stem, I want you to ask, is there any good risk in that individual in the stem of my question? Is there anything on physical examination that suggests that this is a DVT? And then lastly, is there a good alternative risk for some other diagnosis that points you away from DVT? And with that, then, you're going to make your decision whether you jump right to imaging or whether you do a blood test for a fibrin D-dimer. Here is the pretest probability of disease on the left compared to the prevalence of DVT on the right. And what you can see is that with low to intermediate probability of disease, the likelihood of a DVT, in fact, is actually quite low. On the other hand, if they give you in the stem a patient who clearly has a DVT, then the likelihood is about a flip of the coin. This pretest probability of disease assessment is going to greatly help you with your test choice. So, if you have a patient with a suspected DVT, you do your assessment, and you think that they are low to moderate pretest probability of disease, what the boards will want you to do is to obtain a fibrin D-dimer. Why? Because the guidelines tell us that we need to be accurate in our diagnostic strategy such that we miss only 2% of the patients that we see at the time of our clinic visit plus 3 months. So that's how good our strategy has to be. The time we see them plus 3 months, we are only allowed to miss 2%. And what you can see here is that the pretest probability of disease combined with a negative D-dimer has a very high negative predictive value, gets us under that 2%, 99% for low to moderate pretest probability of disease. High pretest probability of disease, the D-dimer is not satisfactory. What they'll do on the boards, if they're asking this type of question, they're going to give you a patient who is either very low or high risk. If they tell you the patient has just had surgery, if they tell you that there's trauma or malignancy, you are not going to choose a D-dimer. Why? Because a positive D-dimer is not helpful. It's only helpful if it's negative because of that very high pretest probability of disease. So read the stem carefully. If there's surgery, trauma, malignancy, then you're not going to be active bleeding. You're not going to choose D-dimer because it's not going to be helpful to you. So you do your pretest probability of disease assessment, and if you're low to moderate pretest probability of disease, then a D-dimer. If it's negative, you are done with the reasoning that I just shared with you. If it's positive, or if you have high pretest probability of disease, then you need to move to imaging. If you have high pretest probability of disease, and they give you the option of imaging or treatment while you wait for the imaging, the answer is that you're going to treat and then obtain the imaging. If they give you a scenario where there's going to be a time lag from the time you order your test till the time you get the test results, maybe they'll say that you're working, for example, in a rural clinic, there's going to be a clear 4-hour time delay, then you would treat. Why? Because the risk of a single low molecular weight heparin injection or a single dose of a DOAC is so low compared to the risk of not treating that acute event, you're going to opt for treatment and then imaging. The imaging, of course, is a duplex ultrasound. Here you have grayscale on the left with color on the right, and you can see that there's a clear filling defect in the femoral vein. But of course, the answer, the way that we do duplex ultrasound imaging is not by grayscale, not by color, it's by compression. And here you can see a non-compressible femoral and profundifemoral vein, and you'll see that this is consistent with an acute DVT. If they show you a duplex ultrasound, they have to show you the non-compressible and the compressible, and it's usually left to right respectively. They have to tell you that it's a compressible on the left. If they're showing you that and you see a non-compressible vein, how is it a vein? Well, the artery is going to have a intimal medial border, and that won't be the vessel you're looking at. But the adjacent vessels, remember the neurovascular bundle, the artery and vein should be in intimate contact with each other. If the vein doesn't compress nicely, that's consistent with an acute DVT, and you'll treat that patient appropriately. The sensitivity of compression ultrasound is quite good. However, notice that it's directly related to the pretest probability of disease. The specificity also quite good, but again, directly related to the pretest probability of disease. This is why for our patients with low to moderate pretest probability of disease, we choose a D-dimer. Why? Because it has a very, very high negative predictive value. So this is to show how important your clinical assessment is. If you have a patient who has high pretest probability disease, they do a proximal duplex ultrasound, but it's negative, you can't stop there. You have to go further. And so you might say, well, come on, a duplex ultrasound, of course it's going to be positive in high pretest probability of disease. That doesn't make any sense. Unless the patient has a calf DVT or an isolated iliac DVT. Then the ultrasound will be negative, but in fact they have an acute event. So D-dimer, if it's negative and you have a negative ultrasound, then that's good enough for the board purposes. That's good enough for guideline criteria. If it's positive, then you need to move on to serial duplex ultrasound imaging. This is the kind of patient where you could choose a CT venogram to look for more proximal thrombotic events. So CT venography, MR venography, these are not for acute management of our patients. We would always choose for a duplex ultrasound unless we're thinking about a proximal DVT or the scenario that I just shared with you. But if they give you out of the chute the choice of a duplex ultrasound or CT venography, MR venography, choose the duplex ultrasound. That is the appropriate test for us. We do a lot more venograms now than we did over the past, say, 10 years. It's becoming very in vogue again, primarily for treatment. So if they show you a venogram, look for the central venous channels, look for big collaterals, look for abrupt cutoffs. This is how you interpret a venogram, a conventional venogram. For pulmonary embolism, it's much the same story. We have to do a pretest probability of disease assessment. Again, you don't need to memorize this. What you need to do is look at the clinical history, look at the physical examination, and make your good clinical assessment. Do you think it's likely or unlikely that that individual in front of you in the stem has a pulmonary embolism? If the answer is, I think it's unlikely, then a D-dimer is a very good choice. If you think it's likely, and again, I don't think they're going to give you moderate pretest probability of disease patient. It'll either be high or low. If you think it's likely, then you would, of course, get imaging. But again, based on the risk of a pulmonary embolism and the associated mortality, if they give you the option of treating and then sending for imaging, that's the appropriate answer for that question. If they show you a patient who has a clear pulmonary embolism and you're thinking imaging, also look in the stem and ask, what's the creatinine clearance for this particular patient? Recall that a CT angiogram comes with the contrast load of about 100 to 120 cc's of contrast. So if they show you a patient who has some renal impairment, you need to be putting that into your decision making, and VQ imaging might be the correct answer for that particular patient. CT angiography carries very good sensitivity specificity. If you have a patient with a high pretest probability of disease, it does quite a nice job. If you're concerned, add a D-dimer. If that's also negative, again, very high negative predictive value for that combination of testing. They're going to show you CT imaging for sure, and what you need to do is look at contrast-enhanced structures and look for filling defects. Very simple, very straightforward, something that you all do in your clinical practice, and this may be part of your board examination. So to summarize our first learning objective then, your clinical assessment is powerful. It's true for DVT and PE. Do that pretest probability of disease assessment. It's quick, it's easy, and you do this all day in clinical practice. Don't immediately jump to imaging. If the patient's unlikely to have a DVT or PE, this is a very good reason to obtain a D-dimer. If there's high pretest probability of disease or moderate to high for a patient with pulmonary embolism likely in the stem, then choose treatment while you're organizing your imaging. All right, so our next learning objective is to design a management plan for stable patients with either DVT or PE, selecting the appropriate length of treatment based on provoked versus unprovoked events. So, from a therapeutic perspective, heparin is, of course, a clear opportunity for treating either of these. If you're given the choice of choosing either low molecular weight heparin or fondaparinux for the patient with an acute event, the guidelines would prefer that you use low molecular weight heparin. Once daily is preferred over twice daily. The boards are really interested in this notion of heparin-induced thrombocytopenia. And so the guidelines are that you would monitor platelet counts every 2 to 3 days between days 4 and 14. If they give you a patient who clearly is going to be receiving low molecular weight heparin or fondaparinux and they ask you, should we do management, or should we do monitoring for platelet counts, the answer is no. Because the risk of hit for these patient populations receiving low molecular weight heparin or fondaparinux is sufficiently low that monitoring is not required. If they show you a patient in the stem and they give you 2 platelet counts, I can't think of any other reason other than they're trying to ask you about heparin-induced thrombocytopenia. So if there's a clear 50% reduction in platelet counts from the first to the second, and in the absence of a prior history of recent heparin exposure, if they tell you in the stem that the patient was previously hospitalized within the past 3 months, then that individual could develop rapid onset hit because of the likelihood that they have ongoing circulating heparin antibodies. If they don't give you that in the stem, they need to tell you that the patient has had adequate time for immunization, which for unfractionated heparin is between 5 and 10 days. They have to tell you that. If they show you a patient in the stem and they're having a new or progressive thrombotic event despite good anticoagulation therapy, you need to be thinking, gee, I wonder if this is hit. And then, of course, there are a number of other causes of thrombocytopenia, but they'll have to clearly tell you that in the stem. If they show you a patient who has heparin-induced thrombocytopenia, and again, because this is so prevalent, I think this would be a wonderful testable question. Remember, you need to stop all heparin exposure, start a direct thrombin inhibitor, either argatroban or bivalirudin, and then start warfarin therapy. Don't start the warfarin until the platelet count has recovered. In the stem, they might give you some pieces of information. Maybe the patient is cirrhotic, and you'll know that, oh, gee, argatroban is cleared by the liver. I better not choose argatroban for this patient. They'll tell you something in the stem that suggests that maybe there's a reason why argatroban is not a good idea, and then bivalirudin would be a reasonable alternative. If they give you the option of using a DOAC, a direct oral factor inhibitor, for heparin-induced thrombocytopenia, the answer is you would not. There's not good enough evidence for this, and the American Society of Hematology says don't use this until further data is available. So if they ask, should we use dabigatran in this patient who clearly has hit, you would choose not to use that for that patient. Which brings up the direct oral factor inhibitors. There are now 4 direct factor 10 inhibitors. Betrixaban was recently FDA approved for DVT prevention. We won't need to know about that, it's too recent. And then, of course, the direct thrombin inhibitor, dabigatran. If they present to you a patient and they're asking you about direct oral factor inhibitor therapy, and they tell you somewhere in the stem that the patient is at a high risk for bleeding, then I would choose one of the agents closer to the right side of the screen. More routes of excretion, lower risks of bleeding, and that would be the appropriate answer for that particular patient. With respects to acute VTE treatment, there have been a number of treatment trials, including all of the now FDA-approved factor inhibitors. They may ask you about dosing, but I don't think they will. I think what they're likely to ask you is a patient, and maybe they're trying to get you to use either dabigatran or edoxaban, and what you need to know is for the indication of venous thromboembolism, you have to treat for 5 days with a parenteral agent before starting those medications. There's no overlap. You give 5 days of parenteral, you stop the parenteral and start dabigatran or edoxaban. If it's a Pixaban or rivaroxaban, you can of course use those out of the chute, and I don't think that you would need to know these dosing differences, but there they are for you. With respects to efficacy in acute venous thromboembolism, there is no difference of any of these agents compared to low molecular weight or heparin or warfarin. So there's no difference between these from an efficacy perspective. From a safety perspective, the only agent that has been shown to have lower risk of bleeding is apixaban. So if they tell you a patient who may have a high risk of bleeding, maybe it's an elderly individual, apixaban would be a very reasonable choice for that individual. So this just summarizes all the treatment, or all the acute treatment trials here. Very similar efficacy for all of the agents. Again, apixaban, safer than other agents relative to low molecular weight heparin, warfarin. And then again, dabigatran and edoxaban. If you choose one of those, you have to give 5 days of upfront parenteral therapy before starting those agents. The guidelines clearly distinguish between acute treatment and secondary prevention. So 3 months of therapy is treatment. Everything beyond 3 months is secondary prevention. And that's true for DVT, it's true for PE. So when you're seeing this kind of question on the boards, the boards want you to ask a very simple question. Was this event provoked or was it unprovoked? And they'll give you a clear provocation. Recent surgery, malignancy, recent trauma, and then the patient will have the event. If it's completely unprovoked, and what they'll do is they'll present you a case with no prior recent history and the event was out of the blue, then that's an individual who you would consider for secondary prevention. And it's all related to, is it provoked, is it unprovoked? That's how we make decisions for secondary prevention. So the guidelines haven't changed with regards to this. If you've had your first unprovoked event and that patient has low to moderate risk of bleeding, that would be an individual who we would have a serious conversation regarding prolonged secondary prevention. If the boards ask you, they give you either provoked or unprovoked. If they give you provoked and ask you, should we do thrombophilia testing, the answer is a resounding no. You would not choose thrombophilia testing ever for a patient who has a provoked event. Since 2012, if they present to you an unprovoked thrombotic event, the answer is no, I wouldn't need thrombophilia testing for that individual either. Based on the 2012 guidelines, the notion of getting thrombophilia testing to try to ascertain acquired or congenital risk factors for thrombosis is now out of vogue. We aren't doing that anymore. It's provoked versus unprovoked, not thrombophilia testing. So there have been several secondary prevention trials with the DOACs, as listed here. Most have been comparing active treatment with placebo. The REMEDY trial compared dabigatran to warfarin, and here are the results. If you compare anything to placebo, the active treatment was a clear winner. With regards to the REMEDY trial, comparing dabigatran to warfarin, this was non-inferior, there was no difference. Here is, I think, quite a fascinating bit of information. It regards the risk of bleeding, major bleeding, for secondary prevention. And I would just have you look at these numbers and be amazed at how low the bleeding rates are for any of these agents. So, to summarize provoked versus unprovoked, if you have a patient with an unprovoked event, you treat them and then you stop therapy, the risk of a recurrent venous thrombosis, either DVT or pulmonary embolism in the ensuing year with no therapy is 10%. Aspirin works, but it's a modest reduction of recurrent rates. And then if you look at active anticoagulant therapy, you can see that there's a clear improvement in the efficacy compared to either aspirin or no therapy at all. And the point is, you can't have a discussion on efficacy without having a discussion on safety. So it turns out that just living normally in the United States or around the world, I guess, the risk of having a major hemorrhage each year, apart from anticoagulation, is about 1 in 1,000. If you're using aspirin, it increases to 0.7%. But look at the low bleeding rates, again, especially for the direct oral factor inhibitors. This is where these have, I think, a home run compared to other therapies. The risk of bleeding is akin to aspirin, making active therapy for secondary prevention with an anticoagulant very, very attractive. What's new in the guidelines is the use of compression therapy. So from the time of 2012 to the most recent guidelines of 2016, there have been several trials that have been done. I think the best trial was the SOX trial, which showed no improvement in post-thrombotic outcomes with compression therapy. So now, if they ask you, should we use compression therapy in our patients with acute DVT to reduce the risk of post-thrombotic syndrome or post-phlebitic syndrome, the answer is no, we do not use that anymore. All right, so in summary, for our second learning objective, for the initial treatment, drug efficacy is similar between agents, and the drug choice will depend on other factors. So look for renal insufficiency, look for a bleeding propensity, look for liver disease. They'll have to clearly spell that out for you in the STEM. For the initial treatment, if you have a patient who has that high risk of bleeding, apixaban is particularly attractive. For provoked events, remember, we only give treatment for a defined 3 months. For unprovoked events, for those individuals who have a low risk of major bleeding, we would continue secondary therapy. Our next learning objective is to design a management plan for unstable patients with pulmonary embolism, considering guideline approach to thrombolytic therapy, IVC filter placement, and surgical thrombectomy. So the big deal with pulmonary embolism is its frequency. We have about 400 to 500,000 events each year, and there is an associated mortality with those pulmonary embolic events. And the risk of sudden death is about 35%. And you should say, gee, I've read a lot of these papers, and that seems high to me. It is high if you only include patients into your trial who make it to the emergency room. But if you include into your trial autopsy studies from individuals who die suddenly, then that number becomes inflated, and probably the correct number is closer to 35%. The risk of the risk of mortality is directly related to the admission blood pressure. So if patients come into the emergency room and they're hypotensive, they have a much higher risk of mortality compared to those individuals who come with a reasonable blood pressure. So whenever we do our assessment of patients with pulmonary embolism, the first thing that you need to assess is that patient clinically stable? If they're unstable, and instability has a very specific definition to it, then those individuals should be considered for thrombolysis, catheter embolectomy, or surgical embolectomy. The way you would choose one of these versus another is depending on the bleeding risk and the contraindications associated with thrombolytic therapy. So for unstable patients who come in with a massive pulmonary embolism, which by definition is unstable, then the number needed to treat for a hard outcome improvement of recurrent PE or death, that's really what we're asking about here, is only 10. So this is a clear winner for those individuals who have massive pulmonary embolism. On the other hand, if the patient presents with stable hemodynamics, then there's never been shown any improvement in these two hard outcomes, recurrent PE and death, if those individuals are given thrombolytic therapy. So the guidelines stay for stable patients coming into the ER with a massive pulmonary or with a submassive pulmonary embolism, that thrombolysis is not indicated. But if those patients are unstable, then if they don't have a major contraindication to thrombolysis, we should be considering that for those patients. The guidelines would prefer systemic thrombolysis over catheter-directed. Remember that you need to look carefully in the STEM, and what does that mean for contraindications? Is there any brain pathology? If there's any brain pathology, if they're actively bleeding, or if there's some other catastrophe which says that thrombolytic therapy is not a good idea, of course, then that would not be a good choice for your patient. For these individuals, maybe they're unstable, but they have a clear contraindication to thrombolytic therapy. These are the individuals who we ought to be sending to surgery or perhaps to catheter-directed thrombectomy. If the patient is stable, however, then the next step is to look at markers of RV injury or RV dysfunction. So, massive pulmonary embolism, these are not infrequent. 1 in 20 patients with PE will have a massive PE, meaning they're clinically unstable when they make it to the emergency room. 1 in 4 patients will have submassive PE, meaning there's a large PE, there's burden to the RV, there's some evidence of RV injury. So we need to know what to look for in the STEM of these patients. So on physical examination, they may give you some clues, an elevated JVP, maybe an RV lift with a right-sided S3, meaning you can only hear it with inspiration, maybe a prominent P2. They may give you an EKG. Look carefully at the EKG. Is there evidence of a S1, Q3, T3 pattern? Now, this is not very sensitive, but when it's there, you need to be thinking that this patient either has a massive or a submassive pulmonary embolism. If they show you a CT scan, have a quick look at the RV. The ratio of the RV to the LV ought to be 0.9 or less. So here's a clear massive pulmonary embolism patient, and you can see that definitely there's an increased ratio of the RV, which is the anterior structure, obviously, compared to the LV. This ratio would be well in excess of 1. That's abnormal. That carries a mortality risk to it. So the next question for submassive PE, we said for massive PE, those individuals ought to receive thrombolytic therapy. For submassive PE, who should get thrombolytic therapy? And this is the recently published PITHO trial, a couple years ago now. This was a study which was devoted to the management of patients with submassive PE. Notice that you needed to be normotensive to get into the trial. 1,000 patients were randomized between tenecteplase and heparin therapy. The primary outcomes, death and hemodynamic collapse within 7 days. You notice that the primary endpoint was in favor of tenecteplase. However, we are really interested in death as the outcome, and you can see that for death, there really was no significant difference for submassive PE patients receiving thrombolytic therapy. But what we will notice is that there's a greatly increased risk of major bleeding. So 5-fold increased risk of major bleeding in those individuals receiving tenecteplase, a 10-fold increased risk of intracranial hemorrhage, making this not a very attractive option for our patients with submassive PE. So in my opinion then, thrombolysis offers no definite survival advantage. It never has for these patients with submassive PE. There's now at least 3 trials showing this. The risk of chronic thromboembolic pulmonary hypertension is low, between 1% and 2% in most studies, and the benefits of improved hemodynamics are offset by the risk of major hemorrhage, including hemorrhagic stroke. What is super important, however, not thrombolysis, but in our patients with submassive PE, what is super important is that we make the diagnosis promptly and start anticoagulation in the emergency room. So this study, you can see that for those individuals who were started on anticoagulation promptly in the emergency room, there was an improvement in hospitalized mortality, there was an improvement in 30-day mortality. It's not just starting the anticoagulant, but they have to be therapeutic within the first 24 hours. So be aggressive, use your weight-based protocols. They have to be therapeutic within the first 24 hours to improve their survival. This is the 6-year follow-up data from the PITHO trial. And so what you can see here is tenecteplase in the red dotted versus placebo in the blue dotted. There was no long-term benefit for thrombolysis in those patients with submassive pulmonary embolism. So no improvement in mortality, no improvement in symptoms, no improvement in pulmonary hypertension, making thrombolysis for the acute management of submassive PE less attractive. So submassive pulmonary embolism, it's very reasonable to start low molecular weight heparin, unfractionated heparin, give them a full 24 hours. If they improve, you're good to go. If they deteriorate over that first 24 hours, these would be the individuals who you might consider for more aggressive therapy. But that first 24 hours, aggressive anticoagulation, this is the way to go. What about IVC filters? They have to show you a patient in the stem where there's a clear contraindication to anticoagulation. They'll have to say the patient's actively bleeding, they've had recent neurosurgery or some major surgery within the recent hours that make an anticoagulation not a good choice. That's the only indication for an IVC filter according to the guidelines, and they'll have to make that very clear in the stem. If they have a patient with contraindications, clear contraindications in the stem, then that would be a patient you would consider for a IVC filter. And so to answer then the next learning objective, describe the antiphospholipid antibody syndrome, diagnosis, and its treatment. So here's a question for you to consider. 54-year-old healthy male, he's evaluated in the emergency room for extensive right leg DVT and bilateral PE. He's on no medications. His mother suffered a DVT. Here is the baseline laboratory data. What is the most appropriate next step for this individual? What would you do for this particular individual? So start heparin and adjust the APTT. Check a lupus anticoagulant later. It doesn't matter if they're on heparin. Recommend indefinite anticoagulation because this patient clearly has a lupus anticoagulant. Test other first-degree family members, or if there's a lupus anticoagulant confirmed, repeat it in 3 months. So just take a quick gander at that one and see what you think. So, the antiphospholipid antibody syndrome, you have to have two components to make this diagnosis. You have to have a clinical event, as defined here, venous or arterial thrombosis, thrombocytopenia, fetal loss, valve destruction, or skin ulceration, plus you have to have a laboratory component. You have to have both. It's not enough to just have the laboratory component. It's not enough to just have the clinical component. You need to have both. If they show you this patient in the stem and give you a wimpy IgG of maybe 20, that's not in keeping with this diagnosis. It has to be more than 40 to be in keeping with the criteria. If they give you a beta-2 glycoprotein 1 antibody assessment and give you a number of 30, that's not enough. It has to be more than 40. And the point is that when you see this, if they give you the option to repeat the testing in 3 months, that's the appropriate answer. So definite antiphospholipid antibody syndrome requires a clinical event, requires laboratory monitoring, and requires repetition. If the lupus anticoagulant or antiphospholipid antibody normalizes in that 3-month window, that's not in keeping with this syndrome. Recall that all of the anticoagulants impair lupus anticoagulant testing, so if they give you the option or give you the question of can we do this on DOAC therapy or warfarin, the answer is no, because of the reduced sensitivity and specificity of that type of testing. If they give you a patient who has a prolonged APTT, like the patient I just showed you, and asks you about heparin monitoring, the only way that you can monitor that patient appropriately is by doing heparin levels. And the goal level, the goal therapeutic level would be 0.3 to 0.7 international units per ml. You cannot use that prolonged APTT for any of your monitoring. That's out of the treatment schedule. One nice alternative for this type of patient would be to convert them to a low molecular weight heparin or fondaparinux because they will not need monitoring. Look carefully at the stem. If the prothrombin time is prolonged at baseline, then you cannot use the INR for monitoring warfarin therapy. You'll need to monitor the chromogenic factor 10 activity for that patient who you're treating with warfarin. You cannot use the prothrombin time INR. The problem in patients who have the combined difficulty of APS and HIT is a real conundrum. Because for the direct thrombin inhibitors, you cannot use the APTT to monitor that type of therapy. So if they give you that type of scenario, the best drug would probably be fondaparinux. Why? Because you wouldn't have to monitor it, you wouldn't need the APTT, and you wouldn't be exposing that individual to risk from the HIT. So if they give you that scenario, I think fondaparinux would be wonderful. I would not use a DOAC for any of my patients with antiphospholipid antibody syndrome. There's not good evidence that that can be used in this situation. And so the correct answer to this question was number 5, that we would confirm the lupus anticoagulant based on the baseline data and then repeat it in 3 months. All right, so the summary points for learning objective number 4 is that we need to look for clues for lupus anticoagulant. This would be a baseline prolongation of the prothrombin time or the APTT. Maybe the patient has thrombocytopenia. This is a common concurrence with lupus anticoagulant. Arterial and venous thrombosis, a history of miscarriage, connective tissue disease, or maybe they have an abnormal valve. That would be relevant. If a lupus anticoagulant is present, you need to monitor parenteral agents using platforms other than the APTT. And again, remember to repeat the baseline assays at 3 months for confirmation. Liebman-Sachs endocarditis, a wonderful relationship with antiphospholipid antibody syndrome. And so my last learning objective is to recognize and appropriately manage lymphedema. Why should we be interested in lymphedema? Because it's the most common vascular disease in the world. So more than 100 million cases around the world. The history is very consistent. This is painless. It's non-dependent. What does that mean? It means that when the patient wakes up in the morning, the swelling is no better than it was the night before. So it's non-dependent, painless edema of one leg usually. The exam is dermal thickening, dermal engorgement of the lymphatics, and it has this peau-d'orange sensation to it, almost waxy in character. The causative factors for this condition in the United States would be cancer, debulking surgery, radiation. Worldwide, it would be filarial infestation. The history is very consistent from one patient to the next. Painless edema, which doesn't improve overnight. The physical examination is important. And then if they give you the option of what test to pursue, it would be a lymphoscintigram, not a lymphangiogram. Here is a lymphangiogram. You won't see many of these in your career, but here is one. You can see these wispy lymphatic vessels coming up to the groin. And once we get into the groin, there's engorgement. And then you get up into the chest, and you can see the reason for lymphedema in this individual. This individual's had injury to the thoracic duct. Treatment is compression, manual lymphatic drainage or lymphatic massage, and intermittent pneumatic compression pumping. So for the learning objective number 5, lymphedema is prevalent. The diagnosis is made by a good history and physical examination and confirmed by a lymphoscintigram, not a lymphangiogram. And then again, management is compression, massage, and intermittent pneumatic pumping. So, final summation, for venous thromboembolism, your clinical assessment is powerful. Use the pretest probability of disease assessment to determine the appropriate evaluation and treatment priorities. Remember, don't just jump to imaging. There are many effective drug choices. Look for other factors when choosing. Is there something clearly in the stem which would point you to one drug versus another? In determining long-term therapy, it's provoked versus unprovoked, very, very clear. And for massive PE, consider lytic therapy unless there's a contraindication. For submassive PE, treat conservatively, as you all do. All right, so.
All right, let's give Rob a hand. You can join me over here.
Yep.
We have this new casual living room.
Oh, I love it. I feel like Churchill.
All right. So let's go through some of these questions and some of the questions that have come through. So the first one is the 34-year-old man, 3-day history of a crampy left calf pain. 1 week earlier, he flew to Florida for a college reunion. He played a lot of beach football but didn't get hurt, which is remarkable in itself. In exam, he has mild left calf edema. The pulses are normal. What is the best step? Is it D-dimer, duplex ultrasound, CT venogram, MR venogram, or start heparin and then get the imaging right away? Okay, so 69% said D-dimer.
So that's a good improvement from pretest, I think.
Yeah. So you want to discuss
Sure.
heparin part
Yeah.
of that?
All right. So I think can we advance to the next slide here? Yep. So this is how, and you could maybe make some argument of how best to assess this individual, but I thought for the pretest probabilities of this individual that he had 2 variables. With regards to Wells criteria. So I gave him moderate pretest probability of disease. Therefore, a negative D-dimer would be super helpful for this individual, would exclude the likelihood of a DVT with very high negative predictive value. And so that's how I scored this individual, making fibrin D-dimer a very attractive choice.
Yeah, so there was a couple of questions about wouldn't you just get both the ultrasound and the D-dimer just straight off the bat? Or since D-dimers are so sensitive now, even in a high probability case, wouldn't that be your best bet? Or you want to talk about the choice between those two?
So in this situation, what we're really looking for is a very sensitive assay, and so the duplex ultrasound is not going to be nearly sensitive enough based on his pretest probability of disease. So we need a very sensitive assay. You can get a D-dimer in most circumstances back within an hour. It's very quick, making this, I think, quite attractive. And so in normal workflow, it might be the workflow to do that. But again, that's an expensive, resource-heavy utilization. So you're getting both the ultrasound and a D-dimer. That makes it, I think, much more resource utilization than it needs to be.
The other thing that you mentioned, in some cases, you're going to get the CT or MR venograms when you're looking for proximal DVT. So in which circumstances are you looking for proximal DVT?
So this might be an individual who has a very good history of, that you'd say, gee, this patient's high pretest probability of disease, but maybe the ultrasound is negative, and then you go on and get the D-dimer and it's positive. This would be someone, for example, who maybe has left leg swelling, and that should trigger in your mind, I wonder if this individual doesn't have the May-Thurner syndrome. So what's the May-Thurner syndrome? Recall that in the pelvis, that's where the right common iliac artery crosses over the left common iliac vein, where you have compression injury of the left common iliac vein and a proximal thrombus. And so that would be the individual who you'd say very likely has a DVT, ultrasound is negative, we have to go further, and so CT venogram is a very nice choice for that individual. However, in the test, we would never dive to a CT venogram or MR venography. We would always start with the ultrasound. In a slender individual, ultrasound of the iliac vein is a very good test. I mean, you can get nice images. It, to some degree, depends on the patient's body habitus.
Okay. So this 34-year-old guy was found to have a left popliteal DVT. His CBC and creatinine are normal. He started on rivaroxaban at the appropriate doses. After 3 months, he comes back to see you for follow-up, and what are you going to recommend? We're going to stop the anticoagulation and add aspirin, stop the anticoagulation and check a D-dimer, stop the rivaroxaban and repeat the ultrasound for residual thrombus, stop the rivaroxaban and obtain a thrombophilia test, or continue the rivaroxaban.
Good. That's a striking improvement as well. The real question here is, was this event provoked or unprovoked? And let's go through the variables here. First of all, he didn't have any trauma. Secondly, he had a plane flight, but it was a wimpy plane flight, right? 4 hours, that's not enough. 12 hours and more, then you could say, gee, I think it's the flight that's participating, but anything less than 12 hours, certainly less than 8 hours, and we can't use the flight as our provocation. So this individual, 4 hours, the flight isn't part of it, and he's otherwise healthy, and so it's an unprovoked event. Because it's an unprovoked event, then, we at least have to have the conversation regarding whether or not to continue anticoagulants. Aspirin. You choose aspirin, and there's data that support the use of aspirin, a couple of trials now, but specifically rivaroxaban versus aspirin, that's the Einstein choice trial, which was published about a year ago. And in that trial, rivaroxaban was a clear winner over aspirin with not increased bleeding rates. So for those combined reasons, I think that the answer of continuing riva is a very good one. And most of you got that right, so good job.
And so that would be indefinite therapy with rivaroxaban?
Indefinite therapy, you talk to them every year and ask, how's it going? Have you had any bleeding? I can also tell you from clinical practice perspective that if the original event was a major pulmonary embolism, we ought to be much more concerned about continuing anticoagulation for that individual. The reason why is that if your initial event was a PE and you stop therapy, your likelihood of having another event is going to be 30% at 5 years. The next event is 2 to 1 going to be another PE. So because of the associated mortality with a pulmonary embolism, if the primary event was a PE, we have to be even more excited and urgent about continuing therapy for that individual. If it's a DVT, one could maybe make an argument of being less aggressive, because if he stops, then the next event is 2 to 1, more likely to be another DVT.
Let me change the scenario a little bit. and this gets to one of your research things. So a lot of times we're faced with the cancer patient who's having VTE. And how does that change the treatment, the acute treatment, and the now prevention for someone whose cause, whose provocation is a malignancy?
As a malignancy. And so that's a great question. And they may show you a cancer. Yeah, very good. Very smart. You're very smart. For the cancer patient, the guidelines say that we should probably use low molecular weight heparin up front. The DOACs are coming on strong. There's a number of good trials that are underway. But for now, it's low molecular weight heparin. And it's at least 6 months. We don't know what to do after 6 months, but the guidelines, grade 2A or 2B even, would say after 6 months, if there's any evidence of active malignancy, meaning is there any tumor on cross-sectional imaging, are they receiving systemic therapy, have they had recent cancer-associated surgery, then we ought to continue those individuals beyond 6 months. But there's no good trial data. That's why the level of evidence and the level of the recommendation is a 2A. So active cancer, continue therapy, and again, this beyond 6 months, we don't really know what agent to use.
And so is it any active cancer that evokes that? Or can't people have DVT unrelated to their cancer, but they happen to have both?
So the cancers are non-melanomatous skin cancer. Any cancer which is non-melanomatous, any skin cancer which is non-melanomatous would not be one of the cancers. If it's melanoma skin cancer and any other cancer, including the hematologic malignancies, then this is an important point. It's interesting for the melanoma patients and also renal cell carcinoma patients. When thinking about aggressive therapies, you need to know that these are the individuals who tend to have brain metastasis. Melanoma is associated with brain metastasis. Aggressive therapy is at risk for increasing intracerebral hemorrhage. So that's maybe an aside, but it's any non-melanomatous skin cancer is out of the picture, but all others are.
Great. Okay. Let's go on to the next question. This is a 74-year-old guy with 2 days of progressive shortness of breath and left leg swelling. He's been healthy until now. He's mildly dyspneic. He's normotensive and his heart rate is 93. His lungs are clear. He's got a subtle peristernal lift and left leg edema. His troponin and BMP are both elevated. Then we have some images, which we're led to believe are abnormal. And we want to know what we're going to do for this patient. Is it going to be thrombolytic therapy, low molecular weight heparin, a filter, lytic plus filter, or surgical thrombectomy?
Yeah, look at that.
Nice.
Very nice. So again, this is the PITHO trial. And so a good 24 hours of aggressive heparin. Remember, start it promptly. Use your protocolized weight-based dosing for unfractionated or low molecular weight heparin, and then watch them. If they deteriorate, then sure, pull the trigger. If there's no major risk factors, again, risk factors would be brain pathology, active bleeding. But if they don't have any of that and the patient is deteriorating despite good anticoagulation therapy, that would be the individual who would pull the trigger for more aggressive therapies.
There was several questions about the ECOS catheter.
Yep.
You want to make comments on that?
Yes, so there are now a number of potential catheters for mechanical thrombectomy. The ECOS catheter is an ultrasound delivery catheter that delivers delivers lytic therapy into the thrombus. The Seattle 2 trial, which was a single-arm trial, suggested that this is a reasonable approach to that type of patient with submassive. It's been our experience that the ECOS catheter has not been nearly as useful as it was promised to be, and we are not using that in our clinic anymore. The AngioVac catheter, which is literally a large volume vacuum that you can use to vacuum out big thrombi in the main pulmonary arteries. We also have some experience with that, but that also has not been that useful. Why? Because it only gets the major proximal vessel thrombus. It doesn't get into the periphery. The catheter system that we're using is a very easy catheter to use. It's an infusion catheter, very steerable, low profile. and it works super great. That's the one that we're using. We're not using Angiovac. We haven't used ECOS for a long time. And so in our practice, it's not been what it was promised to be.